Hey, this is Dr. K from iMedicalSchool, and today we're going to talk about meningitis. Alright, let's get started by talking about what is meningitis. Well, meningitis is inflammation or infection of the brain, spinal cord, and surrounding neurovascular structures. Now, meningitis can be acquired from both community and healthcare settings. The most common pathogens of meningitis include strep pneumonia, Neisseria meningitidis, Listeria monocytogenes, fungal and viral causes as well. Strep pneumonia is generally seen in patients who are adults, specifically patients who range from their mid-20s to about mid-60s. Neisseria causes meningitis in patients from their late teens to their mid-20s. So basically, patients who are young adults are affected by Neisseria. Now, Listeria affects many different types of patients, but generally it affects immunocompromised patients. So patients who have HIV or have been on chronic prednisone use for some reason can generally be affected by Listeria. But most importantly, Listeria affects our elderly population. So for those individuals who are greater than 65 years old are generally affected by Listeria monocytogenes. And like I mentioned before, you can also have rare fungal and viral causes as well. Certain populations are predisposed to meningitis, so patients are immunocompromised. So if you've had an organ transplant and you're on immunosuppressants, if you've had HIV, if you have an autoimmune disorder, you are predisposed to developing meningitis. So always consider that if you present with altered mental status in an immunocompromised patient. One of your differential diagnoses should be meningitis. In addition, complement deficiency can also predispose someone to meningitis. Complements are factors in your blood that help defend your body against certain bacteria. The way they do this is that these complements form complexes and punch holes within bacterial cell walls. So if you don't have C5 through C9 complements, you can develop repeated Neisseria meningitis infections. In addition, patients with history of spinal procedures such as injections, VP shunts, or trauma to the spinal cord are also predisposed to developing meningitis. As you may know, the news has been inundated with numerous cases of patients developing fungal meningitis from compounded steroid shots that were used for spinal cord injections. As a result of these infected steroids, many people have gotten sick and have even died because of the fungal infection present in these steroids. So let's talk about the symptoms of meningitis. There is a triad of symptoms for acute bacterial meningitis, and this includes when patients develop fevers, nuchal rigidity, or means neck stiffness or neck tenderness, and a change in their mental status. Other symptoms that you'll see, especially with other causes as well, include headache, lethargy, seizures, as well as focal neurological deficits. Now, realize that in patients who are immunocompromised or are older may present atypically. So they may just have lethargy or they may just have a headache. So it's really important to tease out the history, see what the risk factors are, and assess their patient for the risk of meningitis. Here's an interesting physical exam finding associated with meningitis. It's called palpable purpura and a petechial rash. These findings are commonly associated with Neisseria meningitis, but note that these are very nonspecific findings. Other physical exam findings include nuchal rigidity, which again is neck tenderness and neck stiffness. In addition, we can do certain signs by bending and manipulating the patient to elicit whether the patient has inflamed meninges. One of those are called Koenig's sign, others called Brzezinski's sign. Now these used to be very popular in medicine to do, but the actual specificity and sensitivity has been kind of overrated in the past. But it's important to know how to do them. So Koenig's sign is essentially when you have the patient flex their hip, and then when their hip is flexed, you try to extend their knee. You will see quite quickly that the patient will scream out in pain. The reason why is that both these signs are testing for inflammation of the meninges. And whenever the meninges are stretched, especially when they're inflamed, the patient will have a very quick pain response. So by extending that knee with the hip being flexed, you're extending that spinal cord and all the meninges and dura around it, and that causes the patient to have pain. Second, you have Brzezinski's sign. So essentially with Brzezinski's sign, you lay the patient down, you flex their neck, and you'll notice they'll automatically flex their hip. And the reason why, again, is their meninges are inflamed. As you flex their neck, you put more tension on their dura, spinal cord, all the neurovascular structures. And because of that pain, they have to flex their hip to relieve that tension in their meninges. So these are two signs you could do, Koenig's and Brudzinski's sign. Again, these should all be done in the light of their clinical history and the probability of them actually having meningitis, because other things could cause these to be positive as well. Now let's talk about the causes of meningitis. So we have Streptococcus pneumonia as one of the causes. Again, mostly seen in mid-adults. It also occurs in patients who are asplenic, so patients who have sickle cell anemia, have had autosplenectomies. They need to have pneumococcal vaccination because they're predisposed to Streptococcus pneumonia infections. Other immunocompromised patients are also infected, so patients with HIV or patients with multiple myeloma or other cancers can also be predisposed to developing Streptococcus pneumoniae. Now, Neisseria meningitidis, now, like I said before, is associated with crowding. So areas like dormitories and military barracks are very commonly affected. Now, that's why we see Neisseria meningitis specifically in younger adults. So those who are living at college or those who have joined the military tend to be younger in age, and that's who are affected by Neisseria meningitis. In addition, complement deficiency, like we talked about before, C5 through C9 deficiency patients are also predisposed to Neisseria meningitis as well. Also, we have Listeria monocytogenes, which is associated with contaminated foods. It is an intracellular pathogen and generally affects patients who are immunocompromised in some way. So patients, again, who have HIV, cancer history, who are on chronic prednisone or other steroid use, as well as the elderly. So keep those risk factors in mind when thinking if a patient has meningitis and what is actually causing it. The last class of infections we'll talk about are gram-negative bacilli. So this is commonly associated with head traumas and neurosurgery. If you have those risk factors in the history, you may want to think about gram-negatives as a cause of the meningitis. Another example would be strongyloides infection. So strongyloides is actually a parasite that you commonly encounter in Asian countries. When you have a significant strongyloides infection, because of the significant amount of hypersensitivity reaction and inflammation, the pores that normally block things from entering your meninges open up. So gram-negative bacilli are commonly co-infected with strongyloides, and you develop a gram-negative bacilli meningitis as well. So it's an interesting association that you may see there as well. Now let's talk about the meningitis workup. So if a patient comes in, you have a high clinical suspicion for meningitis, what should you do? So basically, right off, get some lab work. So you need a CBC with a differential to look at whether they have a leukocytosis, anemia, thrombocytopenia. You also want to get a Chem 10 to see if they have any associated electrolyte abnormalities. It's very important to obtain blood cultures because if they do have a bacteremia, then if you identify the cause of the bacteremia, that's likely also causing their meningitis as well. Now, CT head is kind of a controversial issue in the sense that when do you get it, when do you not? Now, for testing purposes, if you encounter a meningitis patient on a test, if they do not have any focal neurological deficits, then you do not need to get a CT head. The reason is the CT head is there to look out for evidence of increased intracranial pressure, masses, things that would lead to risk of herniation if you were to do a lumbar puncture. Now, in reality, we tend to obtain CT heads in all patients who have a history that is consistent with a meningitis picture. The reason why is that if you were to do a lumbar puncture, even though they have no focal neurological deficits and they were to develop herniation, it's such a catastrophic complication that could easily be avoided by obtaining a head CT. So in reality, obtain the head CT, then do the lumbar puncture. In addition, you also want to get, like I said, a lumbar puncture, but obtain appropriate CSF studies. And we'll go over which CSF studies you should get and in which situations to make sure that you're ordering the appropriate tests. So here we'll go over the different tests and their values and how to identify the different types of meningitis based on these tests. So things you want to look for are color, opening pressures, protein, glucose, cell count with differential, RBC count, and cytology when obtaining your cerebrospinal fluid. Color is normally clear and colorless. Now, opening pressure is the pressure you obtain and measure when you initially enter the CSF space. So it's generally normally 7 to 20 millimeters of water. But note, you should only obtain this if the patient's in the lateral decubitus position, because if the patient's sitting up and bent over, this can falsely elevate or change the opening pressure. Protein should be obtained, and it's usually less than 50 milligrams per deciliter, which is normal. Glucose, generally less than 80 milligrams per deciliter as normal, and your cell count with differential should be about 0 to 5 mononuclear cells are present normally. Now, in cases when there are a lot of RBCs present in the CSF due to traumatic tap, there's a correction factor you can use. So you basically subtract 1 from the WBC count for every 700 RBCs that are present in your tap. But normally you should have no RBCs present in your CSF studies. And finally, your cytology, you should have no abnormal cells, because abnormal cells would indicate a malignancy or cancer present. So other CSF studies you should obtain include gram staining culture, HSV PCR, cryptococcal antigen to identify cryptococcal meningitis, TB PCR to identify tuberculosis meningitis. Also, there are a whole slew of other fungal PCR studies and other viral PCR studies you can obtain to identify alternate causes of fungal or viral meningitis/encephalitis. Now let's take a look at the abnormal values associated with the different types of meningitis. Here I've included a table with all the different values associated with each type, and we'll go through it together. So bacterial meningitis generally appears with CSF that's cloudy and yellow. There's an increased opening pressure, though not extremely high. The protein is very elevated, usually greater than 100, with a decrease in glucose CSF. Now, your CSF glucose to serum glucose ratio is less than 0.2, indicating this decreased amount of glucose in the CSF. Now, your white blood cells will generally be greater than 100 in your CSF fluid, with a predominance of PMN, so neutrophils will be predominant in your CSF fluid in bacterial meningitis. You should have no RBCs present also. Viral meningitis it appears cloudy and colorless in terms of the CSF. There's a normal opening pressure with a slightly elevated protein levels, about 60 to 80. Glucose generally ranges around normal, though they may be slightly elevated at times. WBCs are range from about 10 to 100 with a predominance of lymphocytes. So see that juxtaposition with bacterial meningitis. So neutrophils in bacterial meningitis, lymphocytes in viral meningitis. And again, you shouldn't see any RBCs present also. Fungal and TB meningitis usually has a presentation of straw-colored or cloudy CSF. You have an increased and you can have an extremely high opening pressure in cryptococcal meningitis. And actually, in cryptococcal meningitis, we do serial taps to help relieve that pressure and monitor that pressure. In addition, you can have an elevated amount of protein, usually generally ranging in the 100 area. Your glucose will be normal, and your WBCs will generally be about from 10 to 100 range. And they also tend to be lymphocyte predominant, but you can have a mixed picture. There should not be RBCs present as well, so that should be a common feature among your bacterial, viral, and fungal TB meningitis. Now, HSV/viral encephalitis will have a similar appearance to fungal/TB meningitis in terms of the CSF fluid. You get cloudy and straw-colored fluid. The opening pressure can be normal to slightly increased, with also a normal to slightly elevated protein level. The glucose remains normal, and the WBCs generally also slightly elevated with a lymphocytic predominance. Now, a distinguishing factor in HSV meningitis is that you may see an increased number of RBCs present, and this is due to the nature of HSV meningitis, but generally other causes of viral encephalitis do not cause an elevation in RBCs in your CSF studies. Now, I would suggest pausing here and just reviewing this table again, just to make sure you didn't miss anything before you move on to the rest of the lecture. Now, let's talk about subarachnoid hemorrhage. So, subarachnoid hemorrhage can also be seen on a lumbar puncture if you didn't previously get a CT scan. Generally, you see thousands of RBCs in the CSF fluid. Now, you have to differentiate between a traumatic tap, meaning when you insert the needle, you nicked a blood vessel or got some blood into the CSF fluid, versus actual subarachnoid hemorrhage. Now, traumatic tap, you'll only see maybe a couple hundred RBCs present in CSF fluid, and generally should not be in the thousands. In addition, xanthochromia, which means yellow tinting of the CSF fluid, is seen in subarachnoid hemorrhage and generally not seen in traumatic TAPS. What happens is the RBCs enter the CSF fluid, they lyse, releasing the hemoglobin, and the hemoglobin gives this tint of yellowing to the CSF fluid. Now, if this is present, it is likely subarachnoid hemorrhage because it's a little bit more chronic in nature than a traumatic TAP, which would have happened within seconds to minutes. Now, you can differentiate the two also by serial CSF tubes. So when you're doing a lumbar puncture, you get serial tubes and you number them as you fill them. So essentially, when you get your initial entrance into the CSF space and you start getting fluid out, you start filling tube 1, then tube 2, then 3, 4, and 5 like that. And you have these labeled. And if you see the number of RBCs decrease from the first tube filled to the last tube filled, this is likely just traumatic TAP. Because by the time you get to the fifth or last tube, there should be almost no RBCs present. While with subarachnoid hemorrhage, you'll see thousands of RBCs present in all the tubes with no significant decline between one to the other. So that's how you differentiate between subarachnoid hemorrhage and traumatic TAP. Now we've went over how to decipher what is the cause of the meningitis and the symptoms that patients present with. But now we'll talk about the complications with meningitis. So an acronym is called H-active for the complications of meningitis. So you can develop hydrocephalus, abscess, cerebritis, and cranial nerve lesions. You can develop thrombosis, infarct, ventriculitis, and ventriculopathy, meaning distortion of the brain ventricles, as well as extraaxial collections of pus that can develop due to meningitis and the inflammation associated with meningitis. Now, let's talk about the key points that you need to go home with from this discussion about meningitis. The first is that no matter what, do not delay antibiotics. And we'll talk about the management of meningitis in terms of the antibiotics that should be used later in a different discussion. But remember, no matter what you do, do not delay antibiotics. If you're having to delay it for imaging, just start antibiotics and do the lumbar puncture later, especially if your clinical suspicion is extremely high. 2, identify if you need a head CT or not. Generally, in reality, you'll need head CTs, but for testing purposes, you need to differentiate between if the patient has focal neurological signs or not, and subsequently if you need that head CT. And finally, 3, monitor a patient's neurological status. Patients with meningitis can decompensate very quickly. So having neurochecks in, making sure someone's always monitoring how alert they are, whether they're having focal neurological deficits, is very important in the evaluation and management of meningitis. So we'll talk about the management of meningitis in another lecture, but we've reviewed over the symptoms, the associated causes of meningitis, as well as how to interpret CSF studies. So if you like this video, give it a like. If you have any comments, put a comment down below. And most importantly, subscribe. This is Dr. K from Medical School. I'll see you next time.